what is Gilmore's groin? That's a very good question, and there's still an awful lot of confusion about what Gilmore's groin is. So if I may, I'm going to start with a little bit of history. Now, in 1980, 1981, the late Jerry Gilmore, who founded the clinic, saw three, what were then First Division footballers, who'd all got groin pain, and none of them were able to play. And they'd been out of football for more than 6 months. They'd had multiple tests, multiple opinions, and nobody could work out what was causing the pain in their groin. Now, what Jerry did was listen very carefully to their symptoms and when they got the pain and what seemed to cause it. And he examined them carefully with a detailed knowledge of the anatomy of the groin muscles and tendons. And when nothing else seemed to work, he actually operated on them. What he found was what we call a musculotendinous disruption in the groin muscles, so tears, if you like, in the groin muscles. And because he had a detailed knowledge of anatomy, he was able to repair the groin muscles, and all three of these footballers got back to playing football, two of them internationally, within 8 weeks. So from being unable to play because of pain, he worked out what was causing the pain and how to fix it. And of course, that spawned a whole run of people who developed groin pain who came to see him, and we've seen probably 9,000 people and over 400 internationals have all been treated here. But what people then sort of forgot over the years is that there are lots and lots and lots and lots of things that will give you pain in the groin. It can come from your hip, it can come from the disc at the front of the pelvis, it can come from the adductor muscles, it can come from your back. And it's been a bit lost, this specific syndrome of Gilmore's groin that has a very well-defined set of symptoms and signs. And particularly when you examine people in the right way, you can feel the tears in the groin. And also now you can get detailed MRI scans, which will show, in 80%, it will show changes in the groin that fit this specific syndrome. That is really only a very small number of people who get groin pain, most of them due to all sorts of other things. And I think it's just worth running through the sort of people that get Gilmore's groin and how you spot it and treat it, because there is, unfortunately, a habit now that if anybody has pain in the groin and nobody can work out what it is, they just say, oh, that's Gilmore's groin. And that's not the case at all. And it's very frustrating to find people talking about it as what they often call a diagnosis of exclusion. We can't work out what it is, it must be Gilmore's groin. That's just not the case. So it's nearly always a sporting injury, and it tends to be in young, fit men. And a third of people, there's a definite episode. So typically it's the footballer who gets their leg taken out to the side when they're playing. They get pain straight away and they can't play on, often they'll get quite significant bruising. In 2/3 of people, there isn't a definite episode, and it's more of a wear and tear type event. A little bit goes and a little bit goes and a little bit goes, and then the groin gives out. And there is this very typical pattern of pain during exercise. So, for example, the footballers will find they get pain if they twist and turn. If they kick long balls or dead balls, they find they get the pain. And then they also get pain after exercise. They tend to find they're very stiff and sore for the next few days. And then it slowly recovers. And that pattern gets worse, so that eventually they find the pain is coming on during a game and they have to come off because they can't play. And it takes them more than a week to recover. Now, when you examine these people, there's a trick you have to do, and please forgive me, but you have to put your finger in men up the back of the testicle to feel what we call the superficial inguinal ring inside the muscles of the abdominal wall. And this will be stretched, or what we call dilated, and this is also where the tenderness is. And when people cough, you can feel the muscles bulge because they're torn and split. Now, again, there's a misunderstanding about there being a hernia or not, and people sometimes call this condition a sportsman's hernia. But in a hernia, there's a lump where the contents of the tummy have come through the muscles. There is no hernia here. This is torn muscles. And again, it causes confusion. Now, what we found, working very specifically with our musculoskeletal imaging team, and particularly Dr. Gillan, our radiologist, if you have MRI scans on these people, 80% of the time, you will see the changes that confirm there's a tear in the groin. And that allows you to make the definite diagnosis of this specific syndrome of Gilmore's groin, which you can treat with an operation with a very high success rate. But as I say, we get a lot of people sent to us with groin pain who just don't fit the pattern and don't have it. And in a way, it's disappointing for them because they're told, oh, I don't know what your groin pain is. It must be Gilmore's groin. Go and see the Gilmore's groin team. They'll fix it. And it's not like that, because a lot of the groin pains we see are due to all sorts of other things. And it's just, again, just worth emphasizing, within the whole range of things that cause groin pain, there is this specific set of symptoms and signs that is the musculotendinous sporting injury that is Gilmore's groin. Now, the symptoms of Gilmore's groin are very specific, and they're part of three things you do when you look for a condition. You examine people and you listen to their symptoms, you examine them physically, and then you do some scans. But the symptoms are very specific, and there's a specific set of symptoms that people get during exercise and after exercise. So, for example, people will find if they're footballers, they'll get pain when they try and sprint, when they push off, if they change direction suddenly, if they're kicking, and particularly long ball or dead ball kicking. And if you're, for example, playing rugby union and you're the dead ball kicker, if you're repetitively dead ball kicking, you'll get the pain. And they get the pain in a very specific area, and it's over the area we call the superficial inguinal ring, which is just above the crease in the thigh. So it's actually in the lower part of the tummy. So people point to that area and tell you where the pain is. Now, they also get specific symptoms after they've been playing sport. So classically, the next day, they find they're very stiff and sore. And some people even have difficulty walking for a day or two. And they also find they get pain if they're getting up from a low position. Classically, they say it's painful getting out of bed or getting in and out of a car. Particularly if you've got a low sports car, that can be quite difficult. They also find they get pain if they cough or sneeze, because that stretches the abdominal muscles. So there's a very specific pattern of symptoms of pain during exercise and after exercise, and there's a very specific site of where the pain occurs. So the question comes is, what do you do with somebody who you know has got Gilmore's groin because they've got the right symptoms and signs and they've got the correct MRI changes? Now, believe it or not, we try very hard not to operate on them, and we always try and get this to settle conservatively, so without an operation, with a combination of physiotherapy and rehabilitation. And some of the time it does. It can take a while, but it can settle down. Now, it does depend on what you do. If you're a professional sportsman and your livelihood depends on you playing sport, you're going to want an operation sooner than somebody who's perhaps an amateur or just plays at the weekends, who is prepared to give it more time to settle. And it also depends a bit on what you find on the examination, because when you examine people and you feel this dilated superficial inguinal ring that tears behind it, if that's widely dilated and there's a lot of pain, then probably it's not going to get better by itself. So if people find that the pain is interfering with their job or their normal daily activities, or they're not able to do the things that they like to do, that would be when you think about, do we need to do an operation to fix this for them? So to treat Gilmore's groin, if it's not settled on its own, you need to have a really thorough knowledge of the anatomy of the groin, as the late Jerry Gilmore did when he first worked out what was going on. You need to understand the muscles and the tendons and the nerves and how they all work together. Now, I think almost everybody accepts that the syndrome of Gilmore's groin is a problem with the muscles and tendons of the anterior abdominal wall, so the front of the tummy. And if you recognize that you've got tears in the muscles and the tendons, the muscles at the front of the tummy, then the logical way, and really the only way to treat it with an operation, is to do an operation from the front. So that's a scar at the front of the tummy. And you go through the layers, and there are 3 layers of muscles that you have to look at and repair. And you repair them with stitches that all will dissolve, but you repair them what we call anatomically. So you put the torn muscles back to where they were before they were torn. Now, one of the other things we do as well, and in 2010, Jerry and I had a really good sit down to think about how you could improve the operation. We also do what we call an inguinal ligament tenolysis. Now, this inguinal ligament attaches to the pelvis. It can get very tight, and it can cause some inflammation around the pelvis. People will have heard of a condition called osteitis pubis, which sometimes is secondary to the torn groin. And we just release this tendon as well. So we take the tension off, and then we repair all the muscles anatomically so they're back where they were. And as I say, all the stitches we use will dissolve, so that eventually There's nothing left apart from the normal muscles and tendons back in the right place. Now, people will have heard of some surgeons treating Gilmore's groin with a mesh. Now, I don't see the logic in that, because if you've got torn muscles and tendons, and everybody accepts this is what Gilmore's groin is, you repair the muscles and tendons. If you put a plastic patch, a mesh, over the front of these muscles, yes, you'll stiffen the anterior-abdominal wall, but you're not repairing the muscles, and they still won't work. And I will see people who come and see me and said, I had my sports hernia repaired with a mesh 6 months ago and it still hurts. Why is that? And the answer is because the muscles and tendons haven't been repaired. They've just had a mesh put over the front. And it's the same with the so-called laparoscopic approach, where a big mesh, an even bigger mesh, is put inside the tummy to stiffen the abdominal wall. But if you're doing it from the inside, again, you can't do anything with the torn muscles and tendons on the anterior abdominal wall at the front. So neither of those mesh-based approaches seem logical to me at all. And it's the anatomical suture repair that you need. Our experience with Gilmore's groin and the anatomical repair that we do now has implications for how you fix hernias in the groin. Now, hernias in the groin are a different thing. Gilmore's groin is sometimes described as a sports hernia, but in a hernia, and forgive me, I'm going to use a medical definition now, there is what we call the protrusion of a viscus through the wall of the cavity, normally containing that viscus. So in other words, something inside the tummy pokes through the muscles and you get a lump in the groin. And I think most people are familiar with an inguinal hernia. There's a lump, it tends to go back if you lie down. It's a bit squishy, very common in men. 98% of inguinal hernias occur in men, 2% in women. But it's different from the Gilmore's groin, which is a musculotendinous injury. Now, because to repair Gilmore's groin, you have to really understand the anatomy. That understanding is really useful when you come to fix hernias. And again, I think a bit of history is helpful. Although we've known about hernias since ancient Egyptian times and Roman times, you couldn't really do much about them safely until you had general anesthesia, which really came along the second half of the 19th century. And the pioneer of hernia surgery is probably a chap called Edoardo Bassini, an Italian surgeon, who in the late 1800s did several hundred hernias under general anesthetic. And the way he repaired them was to learn thoroughly about the anatomy of the groin, work out where the hernia was coming through, put the hernia back and repair the hernia and the muscles anatomically, which I'm sure sounds familiar. And that was the way hernias were done really until the 1990s. There's a very famous Canadian clinic, the Shouldice Clinic, that are often known as the hernia factory, where they churn out hundreds of thousands of hernias exactly using this similar suture technique to repair the anatomy. And that's also the way I learned to repair hernias. Now, in the mid-1990s, the Lichtenstein technique came about. Lichtenstein was an American surgeon who decided what he would do is, instead of putting the hernia back and repairing the muscles, just stick a plastic patch over the weakened muscles to stop the hernia coming through. And that became popular because it was felt to be an easier technique for inexperienced surgeons to do. Now, at the time, particularly in the NHS in this country, most hernias were done by what were called surgical registrars, so trainee surgeons. So it's felt to be a good technique for them to do. It was also sold as having a lower recurrence rate and perhaps a lower complication rate. Studies have shown that none of that is true. It doesn't have any of those things. So the reason it was done was felt to be easier for inexperienced surgeons. And that's the way now most hernias are done, either from the front, what we call an open mesh, or with telescope, so-called laparoscopic technique, when even bigger mesh is put on the tummy on the inside. Now that's fine, and I would say that the vast majority of people who have hernias repaired by whatever technique will have no problems. But more recently, the problem has been raised of, do these meshes in a small number of people cause chronic pain, which is really difficult to treat? Now, if you've had a big mesh put inside the tummy using a laparoscopic technique, that's almost impossible to get out. So if you suffer with chronic pain for that, it's almost going to be impossible to cure. If you've had an open mesh technique, you can get the mesh out, and I have done that a few times as a last resort. It's not an easy operation, I have to say, although it's a small number of patients, the results have actually been quite good. But again, it's something you do only when you've exhausted everything else. So if there is a potential problem with the mesh, why use it? And if you've developed a thorough understanding of the anatomy, function, structure of the groin muscles by treating elite sportsmen in Gilmore's groin, and you learn to fix hernias without meshes, why don't we do it that way? And the answer is, I do. And I get more and more people now coming to see me to say, I'd like a hernia repair, I'd like it done without a mesh. And we go through all the things we've just talked about how that's how I learned how to do it. Any hernia operation is a compromise between stopping it coming back and cutting the complication rate. We go all through these things and we give out all the information. And I'm now doing quite a few of these every week now. Hernia repairs like we used to do, dare I say it, in the old days, because we have that thorough understanding of the anatomy of the groin that allows us to treat hernias anatomically.